I must say this is a great honor for me to have Claire as an interviewer. She's one of the nurse leaders that I have admired, mostly from a distance, because we don't get to see each other very often, although we do once in a while. But I have followed her career in the magazines and the newspapers, and I take great pride in the contribution that she has made to nursing. And I am extremely proud to be interviewed by the president of the National League for Nursing, because although you may not know it, it was the National League that first provided a home for psychiatric nursing. When the Brown Report was published in 1948, there was the question of where would psychiatric nursing fit into the new organizational structure. And I organized a committee in New York City of nurses to discuss this matter, and we approached the American Nurses Association for some sort of a council or conference group, and they turned us down. And so then I went to the National League for Nursing, where Helen Nam at that time was the executive director, and she was very much interested in psychiatric mental health nursing, and asked her whether they could provide an opportunity for us. And then we got the Interdivisional Council on Psychiatric Nursing, and that was our first home within organized nursing. Now, of course, we have our own organization, and this may well be the largest group of psychiatric nurses I have ever addressed. When I was doing my speech making, there weren't this many of us. And there weren't this many who were fluent enough to come to a meeting. So I'm very pleased to be here and have this opportunity. Now, I was born in 1909, as some of you may know, which is a long time ago, in Reading, Pennsylvania. And at that time, there weren't too many opportunities for women, particularly if you were in the out of the working class, which was where my parents were at that time. Indeed, the largest group among American citizens was the working class. Then that's no longer true. Now, of course, we have a larger middle class. And so the only opportunities that were available were to go into a convent, to become a teacher, to be a drugstore clerk or work in the 5 and 10, which I had done before I went into nursing, or go into nursing. And the nice part about nursing was, I went into a diploma school, was that they paid you $5, the first $5 a month the first year, 10 the second year, and then we were supposed to get 20 the third year, except by that time we were in the midst of the Great Depression, and so we didn't get any money. But it meant that I was independent of my family and getting what was called an education at the same time. Now, it wasn't a great education, although I wouldn't trade the opportunity and the experience for anything, because it was mostly a work experience, an apprenticeship. But I had an interesting adventure in getting into nursing, and I think it must have been about my second year that I began to make a commitment to the profession, that if I was going to be a nurse, I might as well be a good one, and I might as well learn all that was possible to learn. And so that's when I began to really study, and not just sort of fool around to pass. I began to read the books. Of course, they didn't have too many books, so I could read all of them and feel good about them.
How long does it take you to do the scholarly work necessary?
It did not take very long. In fact, my last year in training was the first time that we had a paid instructor full-time. Other than that, it was a supervisor and physicians who did the teaching. For the last year, they brought in a nurse, Margaret McElpatrick, who had a baccalaureate degree, and she was our first full-time nurse instructor. And she later then was associated with New Jersey. She organized science courses courses for nurses at Rutgers, now the State University of New Jersey. So there's a link between my later experience at Rutgers. Now, what else would you like to know? Interest in psychiatric nursing. In my growing up years and adolescent years, the tendency was not to hospitalize the mentally ill or the social rejects or deviants of any kind. So in the neighborhood where I lived and the schools that I attended, we had people whose behavior was different from the norm as I knew it at that time. And I had considerable interest in them. But the thing that turned me into the direction of psychiatric nursing really had to do with my work at Bennington College. And that had to do with my being able to play tennis. That made me sound like a strange connection. But I was a fairly good tennis player when I was a student nurse. And there was the first woman physician was appointed to the staff of the hospital in which I did my training. And although she was from an upper-class family and therefore not to be treated badly by the male physicians, they did not refer cases to her. They did not let her assist in surgery. And they, in every way, made it very difficult for her. And they wouldn't even play tennis with her, what's more. So she went to the superintendent of the hospital, who at that time was a registered nurse, Hildegard Peplau, and asked whether there were any students who played tennis, and if so, would that student be allowed to play tennis with her from time to time when she was on the premises. And I was the only student who was a good tennis player. So although it was absolutely verboten for nurse students to fraternize with physicians, this was a woman physician, so it was relatively safe. There was no talk of gay, lesbian stuff at that time, so it was absolutely safe. So under the controlled conditions, that it would be an hour, and that we would only play tennis, and we would not socialize in any other way, I was permitted to play tennis with her. And some years later, her college roommate, who happened to be the director of physical education at New York University, and this woman doctor spent a weekend together. And her friend asked her, do you happen to know a nurse who could come up to New York University camp and be our camp nurse? And Dr. Shepard said, yes, I do. She's quite good. And the other requirement was that the camp nurse be able to teach tennis. So anyway, I then was interviewed by her friend, and I went to New York University camp up at Lake Sebago in New York, and I was then camp nurse from 1932 to 1943, every month of June. And I taught tennis. I also taught archery. Not that I knew how to do archery, but I learned and taught it. And I'm in the New York University catalog, too, of those years, as having taught these things. I also taught myself care of physical injuries and taught a class to the students on care of physical injuries. And that was before Howard Rusk. It was long before the rehabilitation thing, but that's another tangent. I won't go off in that one. But anyway, the camp director then at New York University had a friend who was the director of admissions at Bennington College. And she came down to the camp to spend a weekend. And she said to her friend, do you by any chance know a nurse who would be willing to come to Bennington and be our health nurse? They said, oh yes, our camp nurse.
She can also teach tennis.
Yes, she can also teach. They weren't so interested in that. At Bennington, they were more interested in art and dance and stuff. But anyway, I then went up to Bennington and was interviewed. And position and went up there in, I've forgotten now, 36 or 1936 or 37. And the president of Bennington then called me in and said, "You strike me as being very smart. Had you considered being a part-time student while you're here, we will give you a total scholarship." So I had a complete scholarship and became a half-time student. They employed another nurse to be my assistant so I could do that, which was very decent of Bennington. And my only regret is that I haven't gotten rich so I could repay them in some substantial way. But anyway, Bennington College had what was called the winter field experience, which meant that in the wintertime, in order to save oil, because you can remember that in 39 on, we were getting more and more toward World War II. And so in order to conserve fuel, they closed the college for 8 weeks, later for 12 weeks. And the students all went out to some field place where we worked and learned something. And my first field experience was at Chestnut Lodge in Rockville, Maryland. And Frida from Reichman and Harry Stack Sullivan were there. And that's where I got exposed to the Sullivanian interpersonal theory. Not that I ever had any conversation with him because he was antithetical to women. But I did sit at his feet, so to speak. I listened to his lectures, and I was given a copy of his first publication, which was a journal, complete journal issue. And I was supervised by Frida from Reichman. I worked with a patient or two patients and had lunch with her every Wednesday for all the time I was there to discuss the clinical work that I was doing with this one patient or two patients. And she was interpersonally oriented too. And back at Bennington, I took coursework with her ex-husband, Dr. Eric Fromm. So I had, a lot of connection with interpersonal theory. Moreover, Bennington College had two psychoanalysts on the faculty. One of them who was in charge of the college health service until they turned it over to me with the title of executive officer. But so I was exposed to psychoanalytic thinking and Sullivanian thinking for all the time I was at Bennington. I went back to Chestnut Lodge to do another fieldwork experience after that. Incidentally, the first time I was at Chestnut Lodge, since we talked about money before, he said, of course we can't pay you, so I was on my own. But at the end of the experience, he said, you did so well that I'd like to give you a check. I can't remember what it was, $20 or $25 or something like that for 8 weeks. But anyway, it was a confirmation of my competence, although I really was just beginning to learn about psychosis at that point. At Bennington College, we also had a student who came into my office one morning. It was snowing, it was very cold. She put her books on my desk and said, will you watch my books? I'm going up to the barn to take an exam, but I'll come back. I need to talk to you. I don't feel very good. Now, she happened to be dressed in an evening gown with no coat and no shoes and no stockings. And I knew that she was disturbed. It was really a kind of crossroads point for me because I really thought I was a very competent nurse. And here was a situation where I really did not know what to do. I didn't know whether I should give her my coat, put my shoes on her feet, go with her, stop her from going, or what. I let her go to take the exam, which she passed. And then I called one of the psychoanalysts and said, what should I have done? He said, you did fine, forget it. When she comes back, put her to bed and give her a hot water bottle or a feed and sit down and talk with her. Now, most of you know that sitting down and talking with patients is a kind of cornerstone in my work, and that's where it began. And I sat down, and of course I didn't know what to say, so I let her talk. And I learned a great deal. And later that day, we put her on a plane. She flew to, I believe it was Chicago, but my memory gets a little dim. And came back the next semester and finished her college work. So I had a good experience with a very disturbed person who made it all the way back. And I thought, gee, why am I fooling with fruit flies? I was at that point going to be a scientist. And I was taking science courses and looking in a microscope and trying to study these fruit flies so I could learn genetics. It would have been a good thing, except it's too late for me to get into genetics. Well, the field's just coming up now, so. But anyway, that was how I got into psych nursing. And then, to just pursue it for 1 minute, then we got into World War II. And we had a physician change at Bennington, and I decided I'd been there long enough and I ought to go serve my country. So I went into the Army Nurse Corps at that point. And eventually, without too many tangents, I was shipped to England. And we were given a form to fill out to ask how our education and background could best be used in the European theater. And another nurse and I wanted very badly to be in a psychiatric hospital. But we knew the military by then. So we decided that we would have to do something to force them to really look at our credentials. So we put down that we wanted to be in eye, ear, nose, and throat. Knowing there was only one clinic in London, and that was the only one in the whole European theater, and they didn't have any nurses in it, and they probably weren't going to. So we knew that we wouldn't get sent there, but it would force them to look at our record. And we both then were sent to the 312th Station Hospital in England, which was the School of Military Neuropsychiatry. So I spent my whole 2 years with the avant-garde of psychiatry in the treatment of soldiers who had breakdowns in combat. And then that was the beginning of my career in psychiatric nursing.
And then did you get further education between that time?
No, then when I came back, under the GI Bill, I went to Teachers College and got my master's degree. And then the Mental Health Act was passed in 1946, and there were funds available for graduate programs. And Teachers College, the program that I had was really pretty mediocre, and I got in big trouble for constantly complaining about the quality of the program. And so when I left, when I finished my master's degree, I wasn't able to get a job in New York anyway because I was overqualified. I was probably the only nurse with a master's degree who was trying to get a position as an instructor in some psychiatric hospital. And I never made it, so I went elsewhere. Teachers College, in the meantime, was looking for someone to head up their program because they didn't have anyone. They had just visiting lecturers who came in. And so they looked over all their graduates for the past 2 years and picked me with, I think, some regret later. Well, salaries have gone up, and in California, for instance, a staff nurse, a baccalaureate graduate, taking a staff nurse position can start at $35,000 or more, depending on which hospital he goes to work. So salaries have gone up tremendously, but I think also at that time the tendency was to class nurses with domestics, and so that kept salaries low. And it is only since, I would say, the 1960s or 70s that nursing has been able to say with any conviction that this is the knowledge base of nursing, and this is what we do that makes a substantial difference in healthcare and so on. Before that, we more or less did have handmaiden status, and I think that influenced the salary. And once we got into academia, salaries began to be the same for anybody in a particular academic rank. And so that pulled some of us up. Not far enough in my view.
Well, this knowledge base.
I think the whole movement to develop nursing diagnosis has not clearly hit the psychiatric field. And I think we need to do much more work on that, on doing something about what are our diagnostic categories in terms of nursing diagnosis, not medical or psychiatric diagnosis. And then once we do have some understanding or some kind of a list, let's say, of the phenomena that nurses seek to help patients to fix or change or eradicate or ameliorate or relieve or whatever. And once we have that list of what those phenomena are, then we have to develop some descriptions and explanations of the nature of those phenomena, what their origins are, how they develop, how they function, and so on. And from that description or explanation evolve some psychiatric nursing techniques of an interpersonal or psychosocial nature that nurses could use. And then those have to be research tested. Those interventions have to be research tested in a substantial way so that we know whether or not we're getting beneficial outcomes. So you have this three-step paradigm of naming the phenomena, explaining and describing them, getting theoretical understanding of them. From that theory then deriving nurse interventions and then testing those interventions and seeing whether or not the outcomes are beneficial in the short term and in the long term for patients.
Do you know of anyone?
That would be a nice thing. I've been waiting for my MacArthur grant, but it hasn't come. But if I did, I think the first thing I would try to do was to find some institutional setting that would give me a 6-bed or an 8-bed or a 12-bed ward where we would have only nursing personnel working with fairly young first admissions schizophrenics, because that is the #1 psychiatric problem. Now, there are other problems that are equally pressing, but that's the real enigma in this field. And then I think we would get our best people as staff nurses, clinical specialists, and consultants to that unit and see what, within a couple of years, in that nurse-controlled unit, where you had a physician only as a consultant to any emergency medication or continuing medication that the nurses might care to use. Because I think we do have to develop our interpersonal and psychosocial techniques. And that would be the place to do it. And that's where I would put my money.
Well,
Well, this is the decade of the brain, and the biomedicalization of psychiatric treatment is with us. This conference program reflects that. There are a great many programs having to do with medications patients. It's my personal opinion that there will at some point be a backlash against that, and that we will have a swing in the other direction. In post-World War II, we were much more humanely oriented toward the care of patients, and we talked about psychotherapy and counseling and milieu therapy and so on. And now it's almost entirely drug treatment, genetic tampering. I think there will be brain surgery before very long, and other forms of physiological interference with what is believed to be a biomedical causation of mental illness. Now, if you accept that point of view, you then have abandoned the notion of wholeness. You have left out the whole human element, and you have abandoned the concept of mind. And mind is not brain. You know, there's been a lot of argument down through the years. The philosophers and others have argued about what mind is, and there is as yet no satisfactory definition of what mind is. But from my perspective, mind is a function. It is not a body part. It uses every body part. It uses every organ. It uses every piece of the physiological, biochemical structure, but it is not those structures. It is a function of those structures. And that's kind of hard to grasp because we're more concrete oriented. But then, if you accept that kind of definition or something along that line of what mind is, then you have to deal with behavior, which is controlled by the mind rather than by the biochemicals. And I'm always, interested in what gets blamed on biochemicals and genetics and what doesn't. I think that the more we learn about the micromolecular level of human physiology, biology, genetics, the better off we will be. But by the same token, we mustn't lose sight of the human person and the other piece of this wholeness that is one of the common themes in nursing. We're always talking about holistic care, and you're not giving holistic care if you're just dealing with medications. It just isn't the point. And I do think that there was an era there where we didn't blame parents so much as we were looking for explanations, if not causes, within the family and social structure for the development of these behaviors that were seen as deviant. And that was felt as blame by the parents of the mentally ill who didn't understand or couldn't face up to that kind of responsibility. But I know from rearing a child that you have tremendous power over that child. And you know this too, because you have reared, is it one or two? Two. So you know this too, that you have tremendous power over children, and that in the very early years, you really can do things that make or break their spirit. And you can shape their mind. You can shape the way the attitudes that they bring into the world, and they use those attitudes then to interact with other people, and that it is not totally biochemical. So I think this is a very knotty problem because we are in a culture in which the quick fix is in. Everything must be fixed and quickly. And the medications do wipe out symptoms. Now, I have put into the literature an interpersonal way of dealing with the hallucinatory process. There are a number of nurses who have tested that. There are several nurses who have taught it to family members, so that family members who have someone who's mentally ill and hallucinating can use this same technique, and it works. But no one has research tested it. That is, they've done it on a case-by-case basis, but no one has put it to a substantive research test. Although I know it works because I've developed it right out of clinical data. I mean, I didn't pull it out of thin air. I got it from patients, and then having that data from them about what their experience was of actually hallucinating at different stages, then feeding the essence of that into a process of how hallucinations develop and progress. I'd like to see someone research test it with a fairly large sample and in some kind of a controlled or systematic way.
I think Hilda's giving.
Well, I think in terms of the short stay, the basic question is, how long is a constructive experience? And if you think back about your own lives, I think you could probably come up with an experience that was quite brief, but was a defining moment for you. We had a scientist from the Hill School in Pottstown who came and lectured to us about microbiology and biochemistry and stuff like that back in 1929. And this eminent man, told us a lot of facts and stuff. We were not permitted to ask questions of any of the lecturers as student nurses. But one of the students very bravely said, "Sir, if you were a nurse, what would you consider the most important thing to do for a patient?" And the poor man was somewhat perplexed. I mean, this was not his field, obviously. And he looked at her very seriously, and I still have this image of this experience. And he said, "Well, miss, I think I would sit down and let the patient tell me everything that ailed him, how he felt about it, what he thought about it, when it started, and so on. And once I knew all the patient had to tell me, then I would sit down and look at that, and I would try to figure out what it was, what was the real problem that that person was presenting." Now that, for me, was a defining moment. And if you've read anything I've published, you'll see it in there. I mean, it's of a piece with sitting down and talking with a student at Bennington. As for the short term, then, you do what you can do with the competence you have in the time you have. And you do that rather than saying, the time is so short I can't do anything. And you wash your hands of it and say, it's too bad, if I had a lifetime, I could do it differently. You have to find a way to make the time you have with any patient count as much as possible. And that means that what I do know from the workshops that I gave across this country in about half of the state hospitals in this country from 1956 until 1969, that continuing education of nurses of clinical work must go on and on and on. That you have to have clinical, in-service clinical refresher courses for nurses in hospital or in clinic again and again and again. And that the supervisory staff is key to keeping the clinical skills and competence of all staff members at the highest peak and to keep it evolving at an ever higher peak. Now, I don't think the system is ready to pay for that yet. Do what you can under the present economic conditions and hope that we see a new light sometime and provide more money for these kinds of services to nurses within the situation. I don't think our society is yet ready to come to grips with the wholeness problem of the mentally ill person. And I noticed in the panel yesterday, all of the issues that were mentioned, the one that wasn't mentioned was prevention. And there's almost nothing written on what nurses can do in their own families, in their own communities, as school nurses, as industrial nurses, to begin some kind of work that we might call the prevention of a mental illness or behavioral disturbance of some kind or psychosocial problems.
And the problem in that area, I think.
Problem when I went to Teachers College to be an instructor, September the 1st, 1948. And I had such strong feelings about the program that I had taken as a master's student that I was convinced the program had to be improved. But how? You know, to do what? And it seemed to me in thinking about it, I went to the library and read all the psychiatric nursing books and read other journals and gave it some thought. But I ended up deciding that sitting down with one patient, I believe it was twice a week, you did this, and staying with that patient in a talking relationship, we called it talking to patients at that point, later counseling, and it became psychotherapy. And then looking at those data, learning from the experience of staying in a continuing way with one patient for the duration. In the case of the Teachers College students, it was for 16 weeks of the first semester and 16 weeks of the second semester. And then reviewing that data over and over again was experiential learning. And you did that at Brooklyn State Hospital. It was true in our earlier experience, is still true. And that is, if you are a nurse, you almost have guaranteed employment anywhere you go in the world, which, you know, in these times of economic troubles is a good thought. I think also the opportunities now within nursing are enormous. I mean, you can specialize in almost any direction, and there are new specialties being developed all the time. So that whatever your particular interests are in the whole field of nursing, you can light in any one part of it and make a substantial contribution, add to the evolution of the knowledge base, help to develop the profession still further, and make it more beneficial and more meaningful to the citizens of this country or wherever you happen to work. So I think the opportunities in nursing are greater with a guarantee, almost guaranteed continuum of work. The common phrase now is that you will never be in the same job for an entire lifetime, that you will change positions 6 or 7 times within a lifetime. And within the career of nursing, you can easily change positions 6 or 7 times and move up or move sideways and still have the most interesting work, I think, that there is.
I totally.
Well, to be called the lead, our leader at that early point was a terrible burden, let me tell you. And I had really never thought of myself as a pioneer. I thought of myself as someone who, in a sustained way, studied patient data and kept up with the literature, not just in nursing, but in psychiatry and sociology and psychology and other fields, and tried to put this material together in a way that would be useful to the nurses for whom I was responsible, who were working with patients. And that if it was helpful to me and to them, then I ought to tell the other nurses about it. And so I did workshops and lectures and so on. One of my main strategies, I would say, was that from very early on, beginning with 1948 and onward, I made up my mind that I would never disparage nursing. Now, there are things about nurses and nursing. There are things about nurses and nursing that sometimes do make me personally uncomfortable, but I have not disparaged nurses or nursing publicly. I have seen many leaders who do that, and it offends me when they do. And nurses kind of seem to lap it up, it seems to me. But I personally made the commitment that I would do it. I have thought of myself much more as a teacher than a leader. In fact, if you look at some of my earlier speeches and papers, I guess you could say I was a preacher. We were fortunate to have Helen Nam at the lead because she was understanding and sympathetic and very helpful. She helped us organize conferences to get the graduate directors together. Claire did a first research there. They did the first head count of psychiatric nurses in this country, the Nowakowski study. Your study was the function?
Desirable function.
The desirable. Yeah, you wrote.
And then with the first time I tried to draft the paper, she read it and she said, I thought I came from the Pennsylvania Dutch country. And here this New Yorker with, absolutely unable to write a sentence in clear English. But anyway, Hilda fixed it all.
Well, in those days, we had strange notions about research, too. I mean, I'm talking about the 50s. Emma Spaney and I blueprinted the research, and Claire carried it out. Now, she was the smart one. She should have blueprinted it herself, but she stuck with this blueprint that we did for her, but it was a useful study. So if you had a nurse in an organization who had some understanding of the dimensions of the psychiatric mental health problem, then you had some help to push the whole program and the whole profession forward on this. Now, came up with scholarship money for students. The Mental Health Act provided scholarship money. And very bright, intelligent nurses came to study in the program, like Claire Fagan and Gwen Tudor-Will and Dorothy Gregg and Catherine Norris. You know all these names because you've seen them in the nursing literature. So how should I lose? I never say Claire is a student of mine. I always say she's a nurse who studied with me at Teachers College. She has no permanent role. And while I'm very proud of her accomplishments, I don't take the credit because, believe me, she was in the development of the field as a student in the group as much as I was, because by working with this individual patient, going over the data with me in a systematic way on a regular basis, and thinking out loud in the class discussions and so on, the students helped to develop the field as much as I did. And then, of course, I kept in touch with them. And my favorite closing phrase in my letters was, "Write for publication and to me."